Hello, everyone. I'm Dr. Carmen Pugliafito, and I'm here today with Dr. Carl Regillo, who's professor of ophthalmology at the Thomas Jefferson University and director of the Retina Service at the Wills Eye Hospital. Welcome to Retina Synthesis, Carl.
Thank you, Carmen. Great to be here.
Well, we've had some big news lately, which is that there is FDA approval of the first sustained delivery system for anti-VEGF therapy in retina. That is Susvimo, which is formerly known as the port delivery system. And you've had a lot to do with the clinical development of this system. Tell us exactly what Susvimo is.
So Susvimo is, as you mentioned, a sustained release delivery system. That's why we called it the port delivery system. It's an intraocular reservoir device filled with a special high concentration version of ranibizumab. Implanted in the OR, sits securely in the eye wall. Most of it's intraocular. Only a small flange and diaphragm is on the surface of the eye wall, covered by conjunctiva. So the one trip to the OR to implant it and initially fill it, and then thereafter it is refilled in the office with a special refill exchange needle and procedure. So it's a local operation, local anesthesia like outpatient operation to insert the device, and then thereafter it should be refilled in the office.
So just give us a high-level summary of the phase 3 pivotal trial results. What were the key findings?
So we compared the device implanted and then refilled every 6 months on a fixed and regular basis to monthly ranibizumab injections in eyes that have already been treated to some degree, relatively recently diagnosed wet AMD, having a minimum of 3 anti-VEGF injections. And so these are patients that were then randomized to get either the monthly injections or the device in what is essentially the maintenance phase of wet AMD management. And it showed equivalent, not just non-inferior, but equivalent vision outcomes at the primary endpoint, which is the average of weeks 36-40. And so that's about almost up to 2 refill exchange cycles in the monthly injections in the control arm. So equivalent vision outcomes and excellent, essentially identical exudative control based on OCT outcomes.
What was the average duration? How long could a patient go without being refilled on average, or median, mean, whatever you'd like to tell us?
Yeah, now we didn't get that information, of course, from the phase 3 Archway study because patients were refilled whether or not they needed it at 6 months. And in fact, if they didn't quite make 6 months, they could have supplemental injections. That's the way Archway was designed. And the nice thing about Archway is it told us that up over 95, even 98% of patients went the first 6 months without needing supplemental injections. So what that told us is you can reliably get 6 months in nearly all patients. Now, there'll be rare exceptions, of course. It was the phase 2 ladder study that really put the device to the test in terms of how durable it could potentially be. So to answer that, your question, it was in the phase 2 study that same high concentration, 100 milligram per ml concentration of drug filling the device, patients went on average median time to refill, or the durability in essence, was just over 15 months. And so that means a good number of our patients are going to go 6, 9, 12 or more months before they really need to be refilled. Now, whether we do that in practice or not, how we use it, that yet to be determined.
So in the real world, when this system is going to be available, can you give us some advice about case selection?
Yeah, absolutely. That's going to be very important. First of all, the way the studies were designed, clearly we're going to use it, at least at first, in patients that have already been started on their typical anti-VEGF injections. And once they're shown to be responsive, we then may pick and choose the patients or offer it to patients that may be on the side of needing more frequent injections. I certainly am going to start to think about it for patients that, when we do this induction maintenance, if in the maintenance phase you do the treat and extend, you can't really extend them much more 4, 6, 8 weeks. Those patients are going to be really interested in having a device that will give them true sustained delivery and much less frequent treatment, and maybe even less frequent office visits to some degree. For patients that you're treating with wet AMD that are extended with their current injection medicine to 10, 12 weeks or more, they still could potentially be interested or benefit from having sustained release, but they're probably going to be maybe a little less inclined. That's what we predict or expect. In fact, we ran, we meaning me and my colleagues on the Retina Service at Wills Eye, we ran some surveys with patients and doctors and asked the patients and the doctors if you'd be interested in having the device, knowing the safety profile that exists to date, whether you'd be more inclined to have it depending on how frequently you were getting injected. And that's exactly what you would expect. Both doctor and patient tend to gravitate towards offering or getting the device if they're getting injections more frequently.
Mm-hmm.
Now, there are other factors too, I should say, ocular characteristics, for example. Whether the patients had a vitrectomy or not, it still could work in that setting. So that's probably not a deciding factor. But patients that have had a lot of previous conjunctival work, if they've had glaucoma surgery and so forth, the device is placed in the supratemporal quadrant of the eye. And so if there's been a lot of prior conjunctival manipulation from surgery, that's definitely not a good candidate, because it's really important that the device, that the integrity of the conjunctival of the device is intact. And that will help to keep the infection rates low. So if there's been previous conjunctival manipulation, thinning, scarring, that's not a good candidate for sure.
Wouldn't it be ideal in candidates that had no vitreous, because there's no vitreous gel to act as a reservoir?
Yeah, I think so. Technically, we haven't put it in an eye that's had a prior vitrectomy. So when you make that rather large incision, the globe could get hypotenuse kind of quickly. But you're absolutely right. I think we've all had these patients that ultimately have had vitrectomy and need to get injections, and they clear the drug faster and they need their injections more frequently. And the release characteristics are the same, whether there's vitreous gel or not. And in fact, we've had patients that have had vitrectomy with the device in place, and the device continues to work exactly as you would expect.
How big is the reservoir?
So the reservoir, the device itself measures, people say it's about the size of a grain of rice. I guess it depends on the rice. But it's about 8 millimeters in length and about 2.5 millimeters in width. It looks like a bowling pin, and it holds 20 microliters.
So how will the drug be dispensed, basically?
So the drug is going to come in a vial. It's going to come packaged with, in fact, this is new information I just heard, going to come packaged with the device, and it's going to be the hospital or surgery center. It's going to be the OR that's going to purchase that, and together as a unit, including any special instrumentation to insert the device and implant it in the OR. And then there'll also be a vial sold separately that you drop the drug in the office. It's drawn up through a filter needle, and then you have that special 34 gauge exchange needle. That's important. You can't just tap this device with any old needle, because what we're doing is we're actually flushing 100 microliters when we do this refill exchange through the device to exchange it with completely fresh drug.
And what's the volume in the device again?
It's 20 microliters.
20 microliters. The concentration is what, 100 milligrams per ml?
Yep, that's about 10x what we're currently using as a standard intravitreal injection of Lucentis, for example. So
Susvimo refers both to the device and to the drug. Is that correct?
That's correct. I'm sure it's going to cause some confusion, but that's exactly right. So it's the device in conjunction with the specialized high concentration version of ranibizumab.
what about the surgery? How do surgeons learn how to do this procedure optimally?
Well, that's a really important question because this is going to take training. It is a unique procedure. I'm going to say outright, it's not particularly difficult, but there are a lot of unique and important aspects to doing each step correctly and precisely. Because each and every step, if you don't do it just right, has been correlated with various significant adverse events. For example, the wound size has to be very accurate. You make it too small, you increase the risk for intraocular hemorrhaging. You make it too large, you increase the risk of the device dislocating. If you don't close the conjunctiva and tenons layers well over the device, it's a setup for conjunctival retraction, erosion, and exposure device, which is definitely correlated with infection, endophthalmitis. So what's going to need to happen, of course, if you're an investigator, you're going to be very familiar with the latest iteration of the surgical approach because that has evolved, and it's evolved for good reason because various issues and complications that we've had to address allowed for refinement of the surgical technique and mitigation of those problems over time. So the way the surgery is right now is actually pretty good. It should help to keep the complication rates at an acceptably low level. But it's going to take training, and it's a multi-step training process. There's going to be, of course, videos. There's going to be peer-to-peer education. There won't be necessarily formal certification, but the surgeon should go through these steps. And then there's going to be one other aspect to it, which is in person with a surgical device specialist, an SDS is what they're called. So there's going to be a person that comes out, meets with the surgeon, goes over the steps, has in essence like a wet lab, and then is also going to be in there in the OR during at least the first 5 operations. At least that's the plan, the way it's put forth right now. So there's going to be a lot of support in a lot of ways to get this all down in the best way so that doctors become proficient at doing the operation and keep the complication rates as low as possible.
Well, that is impressive. Very, very impressive.
And that's what we had to do in the clinical trial. And in fact, every time we changed the operative procedure, essentially everyone had to be reoriented, retrained. So it was a huge task, especially at the phase 3 level, to do a drug device combination. So it's really a monumental event, not only to have this new treatment available for our patients to be able to offer true sustained delivery, which I tell people, it's not just decreasing the burden, making things more convenient for the patient. It's hoping to get better long-term vision outcomes because it's just more forgiving to have sustained delivery of drug rather than intermittent therapy, which allows for recurrences and vision loss over time.
How many surgeons have actually implanted one of these devices so far? How many have been trained, would you estimate?
Yeah, that's a good question. I don't know offhand, but all the studies to date, and this is now changing, have been US only. So there's probably been anywhere between 100 and 200 that have probably played a role in putting this device in. Now the device is going global, and that's being launched with the so-called velodrome study. And so we're now training, and I'm helping to train these surgeons internationally all over the world. So we do expect and hope that the device is approved in other countries even before the velodrome study is complete. But nonetheless, the velodrome study allows for surgeons across the world to start to get familiar with it, and we start to see the way this rolls out globally. The training process in the US is going to start over the next couple of months. In fact, some programs are already underway.
So what other retinal disorders are being investigated right at this moment?
Yeah, 2 other things are happening in this realm of this port delivery system. Right now, of course, we've got the FDA approval for wet AMD, and the exact same drug device combination is being tested in both diabetic macular edema and diabetic retinopathy without edema. And it's being tested in slightly different ways, different types of treatment intervals and so forth. And right now, those are the only disease states being tested. But there's one other area of research. The same device is also being tested with another type of drug called Dutafab, which is basically faricimab in a fragment form. So that is a bispecific antibody fragment that's being tested in the same device at the phase 1 level for wet AMD.
Well, has that study started yet?
Yep, phase 1 study is already underway. Because you can't just throw in any old drug in this device, especially the larger the drug is, it's harder to get the amount of drug you need. Concentration issues come into play, and the pores on the release control element would have to be different. Right now, that's sized for something about the size of ranibizumab.
So they have different pore sizes for faricimab?
Well, it's the same device, but that's why they had to make essentially a fragment form of faricimab. That's what the Dutafab is. Yeah. So it's probably about the same size, and therefore the release characteristics should be similar.
What's the delivery interface actually made out of? The stuff that's got the pores?
Titanium. The device is
titanium.
Yeah, the device is almost all solid silicone. The diaphragm on the external aspects of the device is soft silicone. That's what you penetrate with the exchange needle. And on the internal aspect of things, to control the release of the drug into the vitreous cavity, is titanium.
What about pharmacoeconomics? So is there going to be a special procedure code for implantation of the reservoir? Is that anticipated?
No. So right now, my understanding is that it will be the same surgical implant code as what we would use for like a Ganciclovir implant.
Oh, I see. Okay, so we have a code for that.
Yeah, so we have an implant surgery code already. So that's, I believe that's what's going to be used.
It hasn't been used very frequently with the dramatic decline of CMV retinitis.
Right. So now that code has been used more recently with the Retisert implant.
Retisert,
yeah, it'd be a similar sort of thing. They think the work value and time involved is similar. Well,
Carl, thanks a lot for your time and the new information that you've given us. This is a very exciting concept and well proven, and it's got a long path ahead in terms of other applications.
Yeah, I think so. I think this is a really big development, and probably the biggest since we've actually introduced the anti-VEGFs, at least for wet AMD. So it's really exciting. I think it's going to really help our patients.
Thanks a lot for your time.
Thank you, Carmen. Thanks for having me.